Good evening to all the attendees. Welcome to the virtual grand rounds of AADMD. My name is Shannon Strader. I am a fourth-year medical student at Lincoln Memorial University in Tennessee, and I am this year's AADMD virtual grand rounds facilitator. For those that are new, virtual grand rounds are a webinar-based presentation model that creates a space for mentorship and exchange of knowledge experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. After this meeting, we will be sending out a SurveyMonkey for feedback on how to improve these meetings. If you have any question throughout the presentation, you may write your question on the sidebar, and we will go over as many as we can as time permits at the end of the presentation. It gives me great pleasure to introduce our wonderful speaker tonight, Dr. David Fray. Dr. David Fray is an associate professor in the Department of General Practice and Dental Public Health at UTSD. He graduated with a DDS from UTSD Houston in '79 and earned an MBA with an emphasis in healthcare administration from Oklahoma City University. After 15 years in private practice, Dr. Fray was a public health administrator in Arkansas and Hawaii for 16 years. He is certified in long-term care by the National Association of Boards, and he is a licensed nursing facility administrator with more than 25 years of experience as a special needs and geriatric dentist. If you would like to go ahead, Dr. Fray, thank you so much for presenting tonight.
It's a pleasure to be with you tonight. I've got information that's going to be good. Okay. It's a pleasure to be with you tonight. I've got information for dental students and medical students, physicians and dentists, nurses, psychologists, advanced practice nurses, just about anybody involved in the field of intellectual disability. I think you'll appreciate this because we're learning more and more about the importance of oral health care, but also the fact that oral health disparities are pretty severe. Now, they're severe in more than just people with intellectual disability. They're severe in the geriatric population, but I think people with intellectual disability have the most severe disparity. So I wanted to talk to you a little bit about it tonight. I'm having a little bit of trouble advancing my slides for some reason. They're just not working.
I think your webcam's on. Maybe that's making things tough. The webcam's on the side, and you don't have to. Yep, there we go. That works. Is it able to work now?
Let's just see.
You can always put it back in the PowerPoint.
Okay.
Not expand it.
Okay, can you see that? How's that work?
Yeah, that works. That's
okay,
fine.
We'll just do it this way. So I have to give this disclaimer because I teach in a university and I'm not selling anything and not being paid for anything I'm telling you. And that the information I give you is not for a specific patient. I do want to go over the objectives. I think oral health and overall health disparity are really important. It's important to know that the disparity gets worse with age. So what we see with children with intellectual disabilities is that we have pediatric dentists and developmental pediatricians that do a really good job, I think. And what happens when people become adults, there's no corresponding specialty to that developmental pediatrician or that pediatric dentist. And so it creates silos. And we didn't get here overnight. It took a long time for us to kind of develop this, and it's different in other countries, and I think that's interesting to know. So we'll talk about some of the policy barriers. The National Core Indicators, this is a survey that's done every year by the National Association of State Directors for Developmental Disability Services, and the thing that they show is that health disparity is greater both in adults, but also due to a minority status. It's also an issue that preventive care is something that's lacking in adults, and that's also exacerbated by minority status. Another thing that's really interesting to me is the health disparity we see with oral health, because this is an example of a gentleman that I met more than 20 years ago, and he had lived probably somewhere around 20 to 30 years in a state institution for people with intellectual disability. And what's interesting to you that are dentists is to notice that he has 2 composite resin fillings on those front teeth. So his ability to be still and be cooperative in a dental chair was not the barrier to oral health care, it was the lack of daily prevention that caused this. This is another example of an individual that I met that is actually root caries. And so we know as people get older that xerostomia due to multiple medications will cause rampant decay. And I think that it goes unrecognized far too long. This is another example of an individual that had a crown on his upper left molar. And so the ability to tolerate dentistry was not the problem, it was daily care. So the importance of prevention just can't be overemphasized. I do want to talk a little bit about the AADMD. For those that know, it was founded in 2002. And actually there was, up in Alaska, there was a meeting. It was a national games, and David Satcher at that time was the Surgeon General. He was the 16th Surgeon General from 98 to 2002 under Bill Clinton and then George W. Bush. And he issued a Surgeon General report called Closing the Gap. This picture of Dr. Satcher shows him actually holding up the 2010 Healthy People objectives. And I think it's really sad that almost 18 years later, we've not closed that gap. It's really pretty sad. This is what he said in his report: the dental health disparities identified in children and adults, and that dental care was largely unmet in the population with individuals with all disabilities. So there's a lot of reports that show this. The American Medical Association said, you know, these individuals are medically underserved. The American Dental Association said the same thing. The ADA went a step further. If you look at it, the ADA actually said in their resolution that they resolved to collaborate with the AADMD and with the AMA. And so I think that's something that we've been able this year to see some progress on, and I'm proud of that. I think the AADMD has done well to work with the ADA. So there's a lot of calls to action, a lot of evidence, there's a lot of studies. Special athletes, healthy athletes data shows that we've got health disparities. The American College of Physicians acknowledges it. I like this slide. Basically, Dr. King said that injustice in healthcare is the most shocking and inhumane form of inequality. The Olmstead decision was a 1999 Supreme Court ruling that just said states are required to place persons with mental disabilities in community settings rather than institutions. But it also said, if you look at the bottom of this, it said that you can take into account the resources available to the states, and that placement in the community can be reasonably accommodated. So the reasonable accommodation clause is what has led to wait lists. So if you're in a state that has a wait list, you can see the number on this slide. I would point out the 2 states that I've worked in: Texas, which is 163,000, and Hawaii, which is 0. So you can see there's quite a few states that don't have wait lists for services for adults with intellectual disability. This is just a graph of the same thing, and the darker the slide, the larger the wait list. Texas has the largest by far. So what happened when we said, okay, we want to move people out of an institution? Well, we got rid of the medical model. So in the institution, what you had is you had a lot of individuals that were different specialties, and they did what was called collaborative care. When we moved people to the community, that ended. So it doesn't necessarily mean that the old way was a good thing. In fact, the movement to community living, for a large part, came because people were underfunded in their care. This was a really famous magazine series of pictures in 1967 called Christmas in Purgatory, where an individual went to different institutions over a Christmas break and took pictures. They were published in a national magazine, and then there were congressional hearings, and the decision was that the institutions needed more money. But 10 years later, there was a realization that money was not the issue, that allowing people to live in their community was actually going to improve their quality of life. But the problem is we've got fragmented care. That fragmented care has resulted partly from the closure of institutions and the loss of clinical people that focus on intellectual disability. So for adults, it's really become a dearth or a shortage of health professionals. And so we really have been working hard with the National Council on Disability to do something about this. Oral health status and oral health problems, well documented. There's also a growing body of evidence that oral health disparity leads to overall health disparity, and that the two are very interconnected. So what do we know about how long people live? We know that what we do as health professionals to fix things doesn't really extend your life, but that prevention and behavior and exercise, that those things are going to extend your life far greater. So as people age, we run into more problems. And so there's limitations to the government system of care. The gaps in services are what we mentioned earlier with the wait list, but also portability. When you move from one state to another, you may have services. When you move to another state, you may go back on a wait list. So it doesn't have portability from Medicaid programs. Dental care is not a required service in adult dental benefits. And so a few states have a waiver, a home and community-based waiver service under dental care, but those are pretty rare. And then I think the largest thing that's a limitation is the misunderstanding of behavior and how people are classified as having behavioral challenges. What about oral health and diabetes? 82% of the geriatric patients with diabetes have severe periodontal disease. We know this. We also know that they have more associations with cardiovascular, cerebral vascular, and peripheral vascular events. So we know that that is not true in people without periodontal disease. Now, these are individuals that are geriatric, but it also is true for individuals with intellectual disability as they age. Disparity by race and ethnicity. This is a CDC report. Basically said that Hispanic children were far later in the age of diagnosis, and that access to treatment and services was lacking for some children. So what are dental graduates saying? 50% of the dental students said they'd never treated a patient with intellectual disability. That's something that has been around. We've known this for 15 years. It's actually getting slightly better. I would say that most dental schools are aware of the problem and are making an effort. The AADMD did a curriculum assessment of needs where they found by surveying medical school deans that most medical students graduate without any clinical training in the care of patients with NDID, and that 90% of the residency programs did not offer formal training. So it was very difficult to have that corresponding clinical expertise that a developmental pediatrician may have. So the AADMD has some strategies to address this. One is the collaborative integrated practice model. This is really nothing more than making sure that dentists and physicians and therapists and nurses, optometrists, anybody involved in the care is actually connected. And we can do this now with technology. So it's a lot of things have really been improved. We've also done a lot of advocacy effort with the Congress, trying to get the medically underserved population designation by HRSA done. And then we've also been able to start curriculum projects with some of the grant money that AADMD has received, and we've connected with medical schools and dental schools. The thing I like the greatest, though, is what we've done with dentistry right now. So I kind of want to share some of that. Some of the new approaches are a caries risk assessment model, integrating the care model with physicians, helping physicians and all clinicians understand how to basically do a referral for dentistry and when to do that and how to do that, and then understanding behavior as communication, and that's what incremental desensitization is about. This is just a graphic that shows what we talked about earlier, and I think the important point is that only 10% of the things we do as clinicians actually extend your life and make life last longer. But if we can do preventive dental procedures, if we can as dentists, be connected to the health home and help identify when people have diet issues and nutrition issues. If we can be a part of a health promotion that promotes a healthy lifestyle, I think as a connected health team, it would be a vast improvement over what we have now, which is a very siloed system of care and frustrates a lot of families in order to try to find care. So what do you see when you look at these teeth? If you're a dentist, you're going to right off the bat know this is erosion. If you're not a dentist, you might be surprised to know that the little yellow color comes when the enamel starts to wear away chemically. And that is a direct result many times with GERD or acid reflux. So if you have a nonverbal patient, it might help to look between the lips and the throat, look at the teeth, look for those changes, get familiar with what those teeth look like. Understand that erosion can really become severe, but the most, I think, severe thing is what's happening down in the esophagus. So we know that Barrett's and the risk for esophageal cancer are important to be able to have early diagnosis of GERD. So if you can diagnose GERD by looking at the teeth, it would be helpful. So this basically tells you the places where you look for GERD. You look on the tongue side of the top back of the top incisors, and you look on the biting surface or the occlusal surface of the molars, and that's the areas that get the greatest exposure to gastric acid. If you're seeing this, you're going to want to quiz and talk to an individual with disability or their family or their caregiver and say, okay, what's going on? How often does a person eat? Have you observed this? Do they ever give you any indication that this might be happening? And so the dentist needs to coordinate the care because the physician would need to treat the acid reflux. So what actually goes on is a great swallow study, and but I can't do it here when I'm in this mode. But when we look at the policy barriers, we look at dentist education. This is the thing that I think we've made the most progress on this year with AADMD. We also have this incremental method for collaborative health, and it really involves working with the psychologist and the behavioral support plan. So most individuals with intellectual disability have a case manager. If you as a clinician ask about the name of that case manager, you can let that case manager know, you know, this person has a real difficulty in accepting dental care. Can we work on that as a part of a behavioral support plan? The other thing that requires state legislation is allowing teledentistry or in-home alternative dental deliveries. So these are some of the things that have been recommended by the Pew Foundation that cause an inequality of qualified providers. So as we look at people, we basically want to make sure that we adapt our system of care rather than asking them to adapt to something that might not work for them. And I think for dentistry, this has been a big problem for many years because we have a system of care that requires patients to come in, be still for 30 minutes at least so that we can bill a procedure. Otherwise, anything we do on trying to provide behavioral support, trying to work with a family and a caregiver on prevention, those things are not reimbursed. So we're procedure based in our dental care. So we're basically asking an individual to fit our system of payment. And if they don't fit in, then most dentists will say, you know, I just don't think I can do this. And I fear that that's headed down a very dangerous place. So the AADMD worked with the National Council on Disability. They had an announcement this week, and they specifically thanked Dr. Perlman, Dr. Spivak, Dr. Rader, and others on the AADMD board. But the National Council on Disability wrote a letter to the American Dental Association last year. And in that letter, they said, you know, in your ADA Code of Ethics, it says dentists cannot refuse to accept patients or deny dental services because of their race, creed, color, sex, or national origin. But more importantly, the code does not similarly prohibit dentists from refusing to accept or treat patients because of their disability. And so I want to thank the National Council of Disability. They also wrote a different letter to the ADA, different part of the ADA, the Commission on Dental Accreditation. And they said, you know, we really want to work with you in the U.S. Department of Education to require dental schools to teach graduates to learn to treat patients with specialized dental care needs. And so in my estimation, I think this has probably been the biggest thing in the last 10 years. From what Dr. Satcher said, to change things, I'm very proud of the National Council on Disability, ADMD, and I'm also proud of the ADA because the ADA just announced this summer that they were going to change not just their accreditation standards, but they were going to change the AAA Code of Ethics. And the language in the accreditation standards says that in the past, graduates must be competent in assessment treatment needs. The new language is that graduates must be competent in assessing and managing the treatment. You notice the word needs has been in red, has a line through it. And then the intent, it specifically says that individuals include but not limited to people with developmental disabilities, cognitive impairment, complex medical problems. So I think it's really important. And the very last thing at the very bottom you'll see, it says that clinicians should be able to assess the treatment needs compatible with the special need and providing services or referral as appropriate. So it's going to take a while to build a network of care, and I compliment the people that are listening tonight because you're the future. And I think we can make a big difference. I threw this slide in. This came from the State of the State reports that University of Colorado puts out every year, and they've been putting them out since 1977. And it basically shows how home and community-based services really shot up in the early 2000s. They kind of peaked and then came back down between 09 and 13, and they've slightly gone up now. The next slide actually shows the same thing for the state of Hawaii, how that the community services really grew. Now this corresponds during the same time that institutions were closing. Hawaii closed all their institutions, but what I thought was significant in Hawaii was how much below the national average Hawaii spends. So that's actually 38.3 or $38,300 per year per person in average waiver cost compared to $53,000 nationally. So the idea is that adults with neurodevelopmental disabilities experience the highest dental disparities. And we know that geriatric populations have disparity that they cannot communicate, but it's only really the ones that can't communicate. For individuals with intellectual disability, their communication is primarily done through their behavior. And so if the clinician interprets the behavior as an inability to become a good patient, then the clinician may miss the opportunity to provide care. So we know that pediatric dentists are well trained in behavior and applied behavioral analysis. We know that general dentists and physicians can get really good at this. We know that we can change the mandated Medicaid benefits, and we know that we can meet dental treatment needs for adults in a different way than we meet them for children, but that we've got to really focus on preventive dentistry. So I just really wanted to lay out the idea that our community dental services should be better than institutional dental services. So as we move people out of institutions, we have to make sure that there's adequate care for adults. We know that there are creative Medicaid options to make this happen. We know that Medicaid does allow for a clinical interdisciplinary team to serve people. We just have to build the ability to communicate and understand. So restorative dentistry is actually changing. And I'm going to go over that a little bit, especially for the people that are not dentists. One of the things we've seen is kind of a expansion of teledentistry and telemedicine. So people say, well, what is that? Well, that's actually providing care in the home. It's not a new idea. It actually has been around. This was in New York 125 years ago. Nurses have been doing this for a long time. Physicians used to do this, go to people's homes. We know that there is a telehealth program for young children with disabilities. It's been very successful in North Carolina. So what does it look like for dentists? Portable dental care. And so it's actually very economical. In addition, it actually uses people that are not dentists. So it could be a dental hygienist or a dental assistant. You can actually train families to do a lot of things. So you think of yourself as a dental home without walls. You actually can deliver care at a lower cost, and you give consumers and families more control. So the barrier of getting to a dental office is no longer there. So it's a lot. There's been a lot of improvement there. This is just another article on telemedicine for California's children. So I think as we look forward to the future, what we might see is more of this being done for adults and adult care. The ADA published this about the oral health special needs consensus statement and recommendations. And in these recommendations, it actually included this idea of in-home dental care. And so you see a picture here of a dental hygienist holding a portable x-ray. You see the dental office being able to monitor through the computer what's going on. So the preventive care, the diagnosis, the triage all occurs. And for those individuals who need to get to a dental office, we can do behavioral intervention and get people very used to being a dental patient in their own home setting before we have the opportunity to go to a dental office. So that's kind of basically the idea of it. We see the same thing in medicine. It helps especially in rural medicine. And so we're seeing this oral health delivery system do a lot of things that before we get to complex procedures. The complex procedures should be done in a dental office, but after a person has really gotten comfortable with being a good dental patient. So these are two more examples of telemedicine. And so I just want you to think about it this way. Individuals with disability need to be connected into an overall health home, and the dental part is just a part of that home. So as we connect overall health, we're going to be able to prevent aspiration pneumonias. We're going to be able to improve nutrition. We're going to identify how many occluding pairs of teeth people have. The medical home and the dental home are going to communicate and coordinate their care. And so this emphasis on health promotion activities, access and referral, really will happen both in the dental home and in the medical home. So I want you to be kind of really interested in this and understand that the transition to adult care for both physicians and dentists that are pediatric clinicians, the transition to adult care many times is not happening. And the need for specialty care is especially challenging for both dentistry and medicine. So these are issues that the AAD continues to work on. There are a lot of things that are happening. You'll hear more about them. But I want you to know there's something really basic and easy. This is supposed to be humorous, and this is kind of hard to think that Clorox at one time had a toothpaste, but they did. They thought that was evidence-based. Today, this is the new evidence-based best practice. This is silver diamine fluoride. Now, there's two companies that sell this in the United States. Elevate was the first one to be approved about 3 years ago. And so Advantage Arrest is used quite widely right now. And what we do know is that it can make a difference. We really do need to come up with other ways. So I'm going to go into how silver diamine fluoride is used in a little bit. But the reason I want you to understand, we've got to have innovative, alternative, different ways of triaging and preventing caries. And so silver diamine fluoride can stop cavities, stop the disease process, the bacterial process that causes teeth to decay. And if we don't do it something differently, if we're waiting on people to learn how to be a good patient, not only do we get poor clinical outcomes that lead to health problems that are greater than just oral health, but we also are driving up the cost at a time that there's really going to be a squeeze in the future. And so it's going to be more and more difficult to come up with adequate funding to pay for a lot of procedures. But if we can figure out a way to slow down and prevent caries, prevent gum disease, we're going to really be able to make a difference in the outcomes of people's lives. Remember that slide, 10% of procedures, or the impact of procedures is about 10% on longevity, but 40% on prevention. So that's what I'm really wanting to drive home tonight. So let's talk about a little bit about Medicaid, because Medicaid is the major funder for adults with intellectual disability. And we see that twice as many physicians participate in Medicaid than dentists, which is interesting. We know that female dentists participate more than male dentists. We also know that the amount of reimbursement is about equal. So it's about 60%. The fee-for-service reimbursement rate for Medicaid is about 60% of the private insurance reimbursement. And so that is something that is with physicians and dentists, but far fewer dentists will participate in a Medicaid program. So we find ourselves between a rock and a hard place, a real difficult place. This is in Hawaii. This is on the island of Maui. And this is a state park called the EON Needle. What's really cool about it is it has an accessible sidewalk. So you can take a wheelchair way back up in this place. I really like it. But it also is kind of a picture of what's going on. We rationalize poor care due to behavior. So a lot of times people come to the dentist and they just don't know how to fit in. It's a scary environment. There's a lot of new people, and we're wanting to invade the personal space of your mouth. So dental teams are focused on, we've got to get something done today that we can bill for. And so that sets up what I call a dental disparity cycle, and I've got a slide to show that. In addition to that, when the dentist gets paid less at 60% of what the normal procedure might be, that's a problem. But for many adults, there's absolutely no coverage, and so families are paying out of pocket. And so a dentist might also assume that the resistant behavior requires anesthesia or protective stabilization. The idea being that the person's behavior that shows that they're not happy about being there in that environment means that they'll always react that way toward dentistry. That's not always true. So what does the DD Act of 2000 say? It says all people with disabilities are viewed as capable of growth and development. And it doesn't say some, it says all. But it also says under the rights of persons with intellectual disability in the same law, the DD Act of 2000, that individuals have a right to appropriate and sufficient medical and dental care. So this is a slide that shows what happens so many times. People come in, they try to schedule an appointment, everybody's kind of motivated, and then the staff attempt, it doesn't work out, the parents get kind of upset, and then they go home. And then the parent calls back and says, oh, we really need care. It might be a person with seizure disorder that fell. So they come in, they try a second time, it doesn't work, and that's when the dentist starts talking about, well, maybe we need to go to the OR, or maybe I'm not sure if I can help your child. And so this happens and families give up. Remember the DD Act of 2000. Don't forget this slide. It says that individuals with intellectual disabilities have a right to appropriate and sufficient medical and dental care. This is the only group of people in the disability world that a federal law says that they have a right to medical and dental care. And the wording medical and dental I've highlighted in red, but it actually is right there together in the rights. So it kind of fits the mission of AADMD. This is x-rays of a person that was an adult whose mom sent me these x-rays and said, you know, I went in, took my child in to have a tooth extracted and came out with 4 root canals. Now this is pretty common because you can't diagnose what's going on with the individual if you can't get good x-rays. And so when people go under general anesthesia, many times they get a lot more done. The problem is the root canals were great, but the next problem was the way the teeth looked later. So the individual was very upset and the mom was very upset about how the teeth looked after the root canals. Even though the decay went to the root, the decay was really went to the pulp chamber, really went deep and had to be done. The parent felt like, oh, this aesthetically didn't look good. So we really have a challenge because a lot of times we're not able to meet people's needs, and it may be due to funding, it may be due to insurance, it may be due to not being able to manage behavior, but it is our job to figure this out. This is another example of the malocclusions that can occur with a really narrow arch. And so as a dentist, this is very frightening for families, and you need to be able to give them an understanding of what could be done. And a lot of things can be done to improve this, but it takes time. And so this is really something that discourages. Just a word or two about fluoride. A lot of different ways to use fluoride. Fluoride's very effective. It does slow down caries, and it's something that families need to know about. But it's also really important that people don't swallow fluoride. And so if an individual cannot swish and spit, you have to really be careful about it. There was also, in just, I think last month, an issue of JAMA, there was an article about fluoride and prenatal exposure to fluoride in pregnant mothers and cognitive concerns in children. So it's very early, and it was a very small number. And what was interesting is the only cognitive decline was in males and not females. I believe it was that way. So we don't really know a lot about what's going to happen in the future in research. And so as clinicians, we should be evidence-based and always looking at it. But right now, you're really pretty safe in saying that fluoride is good for people, except they shouldn't be swallowing it, okay? So that's the important thing to know. The paradigm shift, though, is moving from restorative to bioactive health promotion. So there's new dental materials. We have a concept now called minimally invasive dentistry. I'm going to talk about that, and that it's really connected to overall health. So it starts with a caries risk assessment and looking at how do we reimburse for this. And the old paradigm was we fix things And so the new paradigm is going to be minimally invasive dentistry and stressing prevention. And so what is caries? It's just a medical term for cavities. It's a bacterial disease that you get as an infant, and the bacteria feed on carbohydrate and sugar, so it's a frequency of exposure. You can brush really great at night and really good in the morning, and during the day eat Snickers and candy bars and drink juice all day, and you're going to have a high caries rate. So we really need to understand caries. So it starts in the grooves of back teeth. It also can start in between teeth. If you're not clear, this is disclosing tablets that are used on teeth. There's disclosing solutions, but this shows where people are missing, and typically people miss in the grooves, and that's where the decay starts. So why is there a buzz about minimally invasive dentistry? Well, it actually is going to help people with intellectual disability. There's also research being done around lasers and air abrasion. So there's different ways to do things, and I've already mentioned silver diamine fluoride. So here's an example of a tooth that has a cavity. And so when you want to go in and remove it, you can use a laser and remove the decay. And so you can do this without anesthesia, so there's no needle. And that's a pretty cool thing to be able to do, though it takes a lot of time. And so it can be done short increments, but it is actually, I found it to be faster to use a handpiece and just use the old drill method instead of a laser. But if you fill the tooth, it can look really, really nice after you get rid of that decay. So you look at the previous x-ray, this is, previous picture, here's the tooth, and the next one shows the restoration. And if you look really close, you can see the outline of the restoration. So we can get a lot better. So how does this impact treatment? What's important, this is really for non-dentists to understand, enamel cavitations occur at different rates in different patients. And you really need to be looking at their caries risk. And I gave you the Canberra website earlier, but looking at caries risk could be done by any clinician. Understand that not all enamel defects are going to be cavities and need restoration. So it's really hard to just look at a tooth and know. You really do also need to know that the development phase of permanent molars is occurring when people still have their deciduous teeth. And so you want to make sure that people get the appropriate amount of fluoride, particularly at those ages. And that if we can reduce stress in apprehensive patients, if we can initiate treatment outside the office, we can lower costs, we can improve incomes, and people won't have as many restorations. So the idea of that we've got to be restoring a lot of teeth is kind of going by the wayside. We can actually use an atraumatic restorative treatment to really buy a lot of time. So if you have a person that you need to work on behavior, unless they've got an abscessed tooth, unless they've got decay going to the pulp, we really can do a lot of things to slow down the process of decay while we work on home care and prevention and behavior. And so that's where we work with a unified medical and dental home. And I think getting the behavioral specialist involved early, get a case manager if they have waiver to work with a BCBA, a board certified behavioral specialist. If you get those people to work on a behavioral plan, you can incrementally introduce dentistry into a person's life. So when you're looking at teeth for these non-clinicians, we're looking at stain in back teeth. We're also looking to see, is the stain just in the groove, or is there a darkness under the tooth where you can see it a little deeper? So you really can't tell by looking at the tooth how deep the decay goes. This is a great slice of a tooth that just shows the pulp chamber down there deep in the middle, and the bacteria can penetrate that. When the bacteria get into the pulp chamber, you develop a pulpitis. That's what causes tooth pain. But the process actually starts much earlier. This is an example of, if you looked at this tooth, these are extracted teeth, but you look at the tooth, looks like a pretty good cavity, but then when you slice it in half, it didn't even go through the enamel. On the other hand, here's a tooth that has a similar looking cavity, doesn't look really as bad, but when you slice it, the decay is much deeper. So what's the difference? The difference is decay moves much quicker in some teeth than others, and it really has to do with the genetics of a person, their ability to resist decay as a process. So what do we do? Well, if we see small non-cavitated lesions, we want to seal them. We want to do something to stop them And these are things that clinicians, the physicians who refer to the dentist, these are usually done on molar teeth and not bicuspids or anterior teeth. When we look at a tooth under a really large microscope, we can see that the toothbrush bristle cannot keep the groove clean. And that's where the decay starts. So that's why you seal the groove. That's the reason behind it. Another issue that is coming up, and this was actually a patient that I saw, was not my patient in January of 2009, but was a patient at the dental school, came back to see me much later and had xerostomia. And this is not painful to the person. They didn't realize what was going on, but they actually have extreme root decay. And that can come as you age, especially if you're taking multiple medications. And this points out the real need to have x-rays more often. You can see in this person, they went from 2009 to 2017 with no x-rays. Gum disease, a lot of times for non-clinicians, it's hard to see. But if you look between the teeth, if it's reddened and if it bleeds when you brush or floss, that's an indication that you've at least got something going on with the gum tissue, and people need instruction on how to floss. So I give you a little bit more information on silver diamine fluoride. The research actually was done in China, and it basically showed, it was done with school children, and it showed that it's twice as effective as fluoride varnish. And so the evidence is pretty strong with silver diamine fluoride, and it takes about a second to apply it to a tooth. It literally takes very little time, and it's much more effective than some of the old ways we used to do things. The next slide shows the Interaural Camera that I've used, I guess, for about 10 years. And I really like it because you can give a camera like this to a group home, and you can tell the staff to use it. You can give them to families, and they can go online, and you will have a website as a dentist, and the families can actually send you pictures to show what the home care is like and show you what's going on and if they have questions. It's also a really good way for nurses who are working in facilities, if they see something in the soft tissue, to take a picture and say, hey, what is this? I don't think this is normal. Maybe this wasn't there. And you can also document it. We're using technology to give people visual cues and auditory cues to say, hey, it's time to brush your teeth. It's time to floss your teeth. And you can actually use videos. So people with intellectual disability many times do fairly well when they're regularly, daily reminded to do things. So what can we do and actually to make a difference? We can train people in the natural environment. And what we did in Hawaii is we used peer trainers. So individuals with intellectual disability trained other people with intellectual disability for several things. So we had a lot of hurricanes, and we had tsunamis and earthquakes in Hawaii, and we decided people needed to have backpacks that had all their medications and had everything they would need in case there was a natural disaster. So we started a project with peer trainers, and the initial thing was just to get them ready to, take care of themselves if there was no electricity for 3 or 4 days, because that's happened several times in Hawaii. And what was the beauty that came out of that was that we found out that individuals with intellectual disability that were adults were also teaching people how to brush and floss, and the importance of that as a part of getting ready for hurricane preparedness. So I learned a lot from individuals with disabilities in my time in Hawaii, and we learned that we could also recruit a dental team. And so we had something called PICLE, or Partnership for Inclusive Community Living. And we got the dental team to become a part of a health home that was a virtual health home, but was also out in the community. And we got dentists and dental assistants and dental hygienists out of the office. And what we learned is that if you worked incrementally with people where they lived and worked before they came to the dental office, we built a bond of trust. And once that bond of trust occurred and we knew that we could clean teeth in their home, we could then be successful when we had to go to the dental office. So there was a lot of really good lessons learned there in about a 5-year project that we did. So the incremental care model, I think, really works. So what are the outcomes? Well, it's shared responsibility for learning oral hygiene. You don't just learn it a couple of times a year at a dental office. You make sure that the family understands it. You give them videos. We use technology. You make sure that all parts of the health team understand the importance of oral health. And then we actually saw people's oral health improved, and the cost ultimately went way down. And we also eliminated the need to take people to the operating room in a hospital, so there was no OR time to actually fix teeth. So my question is, will you be a fixer or a server? I think we all need to be servers. We need to be advocating for integrated healthcare. It's an essential part of dignity and respect for all people. And I hope that maybe some of this discussion tonight has started some questions. So with that, I'll turn it back over to Shannon. And if you have any questions, I'll be happy to answer them.
Thank you so much, Dr. Fray. This was very enlightening and very, very well done lecture. If anyone has questions, can you please type in? Otherwise, we'll just end early-ish. So far, there's no questions.
Okay, well, I want to thank everyone. I think that's fantastic. I'd encourage you to come to our annual meeting. AADMD's meeting next year is going to be in Pittsburgh, and hopefully you guys will be there. I always look forward every year to the opportunity to connect to people across the country. We have quite a few international attendees as well. Thank you very much.
Thank you so much. Have a great night.